first question goes to Alizera. Okay? Alireza, are you here? Alireza?
Yes, I'm here.
Okay, now let's see the first question. Okay, let's see the first question.
So to turn. Okay, what is the direction of change in the parameters below during respiratory acidosis?
Okay, what is the respiratory acidosis and what can cause respiratory acidosis?
For example, in case of hypoventilation, in case of COPD, pneumonia, or...
Good, very good. So when we do have an accumulation of the
carbon dioxide
level. Okay, very good. Okay, so what will happen with the actual bicarbonate level if we do have an elevation of the CO2 value?
Oh, it will increase.
All right, because this is due to
because carbon dioxide reacts with water and dissociates into protein and bicarbonate.
So if I want to write it, I can write right there, okay, plus water that makes, when it's dissociated, it makes, let's see, the proton and makes the bicarbonate. Yes? This is how it's going on. Okay, that's fine. So when we do have an elevation, for example, of the CO2 value, that shifting the equation to the right. So it's meaning we do produce more proton and more bicarbonate. Okay, that's it. And because the pH is a negative logarithm of the hydrogen ion concentration, this is why we do have an acidemia. So that process is a respiratory acidosis, but meanwhile, we will produce bicarbonate. Now, the amount of bicarbonate that produced here is not too much. It's about every 10 millimercury of CO2, so 10 millimercury of the CO2, it will increase the bicarbonate around 1 millimole per liter. All right, so this is relatively, is not going to alter too much the normal bicarbonate value. This is why in an actual bicarbonate in an acute situation is still in the normal range. Okay. All right, what about the standard bicarbonate?
It doesn't change.
Okay.
In the beginning, yes.
Why?
Because it takes time, and for example,
no. What is the difference between the actual bicarbonate and the standard bicarbonate?
And for a standard bicarbonate, we normalize it with PCO2, and it only talks about the metabolic process. Actual is respiratory and metabolic processes that lead to increase of.
Okay, all right, now let's see. I show you something, maybe I can draw a picture and you will understand. Okay, we are taking, let's see, a beaker, all right? That beaker is full of water, okay? That's it. This is what we start with, all right? Good, that's water. So we do have water in this beaker. And what we do, we start and gas this water with CO2, okay? So we will put some CO2 into this water. So first of all, we do have the water. And of course, what will happen based on the equation what we had, the CO2 plus the water, that's going to make, as we discussed, all right, proton and bicarbonate, okay? This is what will go. Now, if I draw a graph and meaning this graph, okay, so this graph, All right, maybe this is too thick. Okay, I do it right. Okay, we don't need that big one. Okay, so that is going to be the graph, what I'm going to draw here. So here I have the bicarbonate value. Okay, this is the bicarbonate value. And here I do have the amount of CO2 that I'm going to put into this water. So what will happen when I have this kind of situation? If I do more CO2 put into water, that is going to increase the bicarbonate concentration. Yes, that's clear cut. So this line is going to show you how the bicarbonate level will increase into this water. So this portion is depending only on the CO2 value. So I would call this is a respiratory portion. Okay. All right. So far is understandable.
Yes.
Yes. Okay. Now, what will happen if I put into this water, for example, sodium bicarbonate? So when I put sodium bicarbonate, I will go the green one. So it's meaning at 0 time, without putting any CO2 in the system, I do have some bicarbonate in this system. Yes? So this is how the graph is starting. And when I start guessing it, I do have a parallel line with this one. Now, so if I put more, that will increase. The slope, however, is going to give us the respiratory portion. So in every given portion, if you, for example, not red, the green one. So if I want to, for example, to see the CO2 value here, the CO2 value here, all right? And that's meaning I do have some, is I would call as a metabolic portion. This be the metabolic portion. And some the respiratory portion. This is why the actual bicarbonate that I do have right here, this is the actual bicarbonate, okay? That's the actual bicarbonate. It will have a metabolic portion and the respiratory portion, all right? So this is understandable. So the problem is that this actual bicarbonate is depending on both respiration and metabolically. To eliminate the changes of the respiration, what they did, they said that, okay, I want to set the bicarbonate value at 40 millimercury all the time. So it's meaning that when I draw or when I'm measuring the bicarbonate at 40 millimercury, as I draw here, you can see that the respiratory portion always the same, because this amount of respiratory portion that is given by a 40 millimercury of CO2. And if you do have any difference at PCO 40, that only could be due to the metabolic changes. Yes?
Yes.
All right. So this is why they set the PCO2 value to 40. Now, this is going to give you another important things. If the CO2 value is less than 40, okay, if the CO2 value is less than 40, maybe I can use, let's see, that's less than 40, okay, what does it mean? It means that the actual bicarbonate is less than the standard bicarbonate, because that would be the standard bicarbonate at CO2 40. Okay, and if the CO2 value is bigger is bigger than 40, the actual bicarbonate is bigger than a standard bicarbonate. Yes? All right?
Yes.
And the difference is whatever amount of CO2 is different between the 40 and the actual that is the patient has. All right? So this is the difference between a standard and the actual bicarbonate. Okay, now let's go back. What about the base excess?
It doesn't change.
Exactly, because the base excess only changed metabolically. There is no influence the respiratory portion. Okay. What do we call as a base excess? Base excess, when they introduced, that was a measured parameter. They measured how much acid should be added to the plasma to normalize the pH. However, today they are not measuring, not titrating, they calculating based on the buffer base and the subtracting the normal buffer base to the actual buffer base that they're measuring. And because the buffer base, the sum of the buffers is changing metabolically only, but okay, what is the buffer base? Who can tell me what the buffer base is?
So the overall base content of the blood.
Yeah, it's true, but if you see, the buffer base will include, for example, hemoglobin, that's fine,
Proteins.
all negative component. It will include the HCO3.
Okay.
Yes, it will include, or protein, okay. And as if you look at here, you would say that, yeah, this looks like, because the bicarbonate is a portion of the buffer base, this buffer base should be influenced by respiration. However, when you produce one bicarbonate, you will produce one proton as well. And what will happen with the proton? If you watch the other movies as well, you will see that this proton is buffering the hemoglobin. So what will happen? This proton goes to the hemoglobin and you're gaining one bicarbonate, but you are losing one hemoglobin. So this is why the buffer base at this pH where we live does not alter by respiration, only metabolically. Okay?
I'm sorry, no, I did not get that.
Okay. When we go and when we do the red blood cells in the periphery, what will happen? Inside the red blood cells, we do have the carbon anhydrase enzyme. CO2 diffuse into the red blood cells, yes? And associated with the water and making bicarbonate and proton. Yes?
Yes.
Okay.
Yes.
At the same time, the oxygen is diffused out from the hemoglobin. So we do have a negatively charged hemoglobin. Negatively charged hemoglobin is a very strong basic component. So to prevent the, let's say, the alkalic milieu inside the red blood cells, the proton that is accumulated during this carbon anhydrase action, this is buffering the negatively charged hemoglobin. So what happening? The proton bound to the hemoglobin, you are losing one anion, hemoglobin ion, but you are gaining another anion, such as a bicarbonate. But 1 mole. So this is the no changes of the basic component of this buffer system. Okay. Now, in the lecture note, you will see it when we do have the lecture on the next week. I'm going to explain it and you will understand easily. But only that you can say that at this pH, when we do have the dissociation of the hemoglobin and the hemoglobin be a negatively charged anion, and when the proton is released, immediately that neutralizes the hemoglobin, the negatively charged hemoglobin. All right? So you are losing one component of the basic component of the buffer system, but you are gaining another one. because it's one molecule of proton made and one molecule of hemoglobin lost, but one molecule of an ion is gained as a bicarbonate. Okay?
Excuse me?
Yes.
When proton enters RBC, is it an exchange process with
No,
chloride?
Inside the red
Inside.
blood cells, we do have the carbon anhydrase enzyme. And that's going to catalyze this reaction that I'm drawing here inside the red blood cells. And you do have hemoglobin, oxygenated hemoglobin inside the red blood cells, yes?
Yes.
Okay, but in the periphery, what will happen with oxygen? Is diffused out. What is left? Negatively charged hemoglobin. Yes?
Right.
And from the periphery, the oxygen goes into the peripheral tissue, but in return, the CO2 diffusing inside the red blood cells. And the produced proton neutralizing the negatively charged hemoglobin where the oxygen dissociated off, okay?
Okay.
So this is why the buffer base is not changing. Yes?
Does chloride play a role in? I just remember something
Yes, the chloride plays an important role because what will happen? Inside the red blood cells, we do have an accumulation of bicarbonate. However, the bicarbonate exchanged by chloride. So bicarbonate goes out to the plasma and chloride enters to the red blood cells. So from the periphery, the bicarbonate that made with water and CO2 is traversed to the lung in a plasma. But inside the red blood cells, we do have the proton bound to the hemoglobin plus chloride. And the opposite will happen when we do have inside the lung, because inside the lung, we do have the oxygen replacing the proton from the hemoglobin binding, and everything goes backward. So what will happen? Now it's using up the intracellular stays a little bicarbonate, and this bicarbonate gradient that coming from the plasma goes inside the red blood cells, and this is how making the CO2 diffuse out, and we exhale the CO2. Okay, please leave everything for the lecture, or you can watch the lecture video, another possibility. That's physiology, completely physiology. Okay? Hello, guys.
Yes, yes.
Yes.
Okay.
Can
Now,
I do the second question, or are we not done with it?
yeah, okay, you can do that, but first we should finish it. Okay.
Okay, my bad.
Okay, let's see, Alireza, what will happen during compensation.
In the actual bicarbonate concentration, it increases even more.
Okay, what will happen when we do have compensation? So what is a compensation?
For example, when carbon dioxide concentration, partial pressure increases, bicarbonate concentration must be also the same direction, also increases, and that's compensation.
This is not a compensation. This is not a compensation. Respiratory problem cannot be compensated respiratorically. The respiratory alteration compensated metabolically. So the kidney plays an important role, and because we do have an excess of proton, this proton is secreted by the kidney and gaining bicarbonate. So the kidney will generate metabolic acidosis to compensate the respiratory acidosis. Okay?
Metabolic
alkalosis. Yes,
Alkalosis.
metabolic alkalosis. So it's what will happen. You do have a metabolic alkalosis. I will draw maybe a different color. I don't know how can I change the color. Okay, let's stick to this one. Okay, and again the buffer base increases as well. Okay, now we do have one arrows that goes as a part of the respiratory acidosis, an additional bicarbonate that gained by the kidney. Okay, so now we do have two different situations. One as a metabolic alkalosis, and due to the respiratory acidosis, we do have a further increase of bicarbonate. This is what you do see here, because now we are here at the beginning. This is why the standard is not changed. But what will happen? We are gaining a little bit more metabolic component of the bicarbonate, so the actual bicarbonate increases further. Okay?
Okay.
More or less. Okay. Now, Amir, you wanted to have the next one?
Yeah, I want to talk about diabetic ketoacidosis.
Okay, now talk about the diabetic ketoacidosis. Okay. Yes.
Okay, so diabetic ketoacidosis, how and why do the indicated parameters deviate from the normal? The pH, the CO2, the buffer excess, the carbon, the bicarbonate, and so on. Okay.
Step by step.
Step by
pH.
step. First of all, diabetic ketoacidosis. Well, it's acidosis, so pH decreases.
Okay, so we do have acidemia, yes? Okay, yes. So the pH goes down. Good, very good. What will happen with the CO2?
The CO2 will not change.
Why? Do we have any uncompensated metabolic situation? There's no way, because the respiration should immediately compensate, normalize, because depending on the hydrogen ion concentration, the respiratory center is stimulated. If you do have acidity, respiratory center is firing more. So the patient will have hyperventilation. And due to the hyperventilation, what will happen with the CO2? Will decrease. What kind of breathing pattern the patient has who has this diabetic ketoacidotic situation? Kussmaul breathing. So there's a maximum amplitude with a maximum rate. All right. Now, what about the base excess?
It decreases.
Yes, because we do have a metabolic acidosis in process. Okay. What will happen with the actual bicarbonate?
Also decreases.
Exactly, also decreases. And what about the standard one?
Also decreases.
Okay, now let's see whether the standard and the actual is the same.
Are you asking me?
Yes.
Are they the same?
They equal or not?
I think pretty similar in this situation, no?
No, that's not. CO2 less, because CO2 is less, meaning that the actual is less than a standard. Because you put less CO2 into the solution as a respiratory portion. All the time, if the CO2 less than 40, the actual should be less than a standard bicarbonate. All right? If the CO2 is a bigger one, the actual is bigger than a standard. Look at the first question.
Yeah.
Okay. Now, what about an ion gap?
An ion gap will be increased because of the increase in the amount of anions.
Amount of acid. Let's see, amount of acid. Now, an ion gap is used to specify the underlying cause of metabolic acidosis. If we do have an acid production, the proton buffered by bicarbonate, this is why the bicarbonate will decrease, all right? So if you remember what an ion gap is the equation of the sodium, Oops, what happening here? I'm sorry. Okay, so, all right. Oh, no, that's one. Okay, so what is the anion gap? The anion gap is sodium minus, I'm sorry, minus bicarbonate plus chloride. Okay, and this is should be around 12. Now, if you do have an acid produced, okay, if you do have an acid produced, this acid is going to neutralize by okay, polygon, neutralized by bicarbonate, okay? So the acid increased and making water, and the water dissociated backward to CO2 and the other situation, all right? So this way we have less bicarbonate, and because we are subtracting less bicarbonate from the system, this is why the anion gap will increase, okay? Now, if another possibility, if you lose bicarbonate through the kidney or through, for example, the GI tract, what will happen? The bicarbonate exchanged by chloride. So as much bicarbonate lost, the chloride gained back. Okay, so that's called non-anion gap acidosis. So to see whether we do have an acid overload or we do have a loss of bicarbonate directly, this is how we can differentiate as an anion gap acidosis and a non-anion gap acidosis. Okay?
Yes.
All right. Now what about the potassium?
The potassium will also be increased for two reasons: the effect of insulin on the sodium potassium ATPase. So because of insulin in this diabetic ketoacidosis happens in type 1 diabetes. So because of that, we have, and the second one is because of the acidosis itself. The potassium proton exchanger is working, so protons pumped into the cell and potassium outside of the cell, and that increases the serum potassium.
Okay, so you can remember that if we do have acidemia, the potassium level is higher, mostly due to the buffering. The intracellular milieu buffers the proton. Proton moves in, potassium gets out all the time. So it's very simple to understand. More hydrogen, more potassium in the extracellular places. Less proton is in alkalemia. You do have hypokalemia. All right, this is what you should remember. Okay. Now, this is what we do have right here in a second one. Okay, let's see the third question. And Astrid, Frida?
Yeah, I'm here.
Okay.
Okay, so we have a traumatic shock. These are the acid-base parameters.
Okay.
So we see that during the first hours, the pH is low, so we have acidemia.
Very good. We do have acidemia. Okay, good. PCO2?
It's also low.
Okay, so it's also low, all right. So it meaning this can explain the acidemia. The changes of the PCO2 can explain the acidemia.
It could.
Why?
Decreases the pH.
No. If you have less CO2, you have less proton. So it's meaning that's a respiratory alkalosis, the process. Okay.
Yeah. So then it's compensating for something.
Exactly. That could be a compensation. All right. So that could be a compensation. Okay. Next one. Let's see the following one. Actual bicarbonate.
It's low.
Okay. So can it explain the changes of pH? If you do have less bicarbonate, that's a metabolic acidosis.
Yeah.
Doesn't matter whether an acid was taken or by loss directly. Okay. And what about the standard bicarbonate? Again, showing that, yeah, we do have a metabolic acidosis. And as you see here, see, actual bicarbonate is less than a standard bicarbonate because the standard bicarbonate was measured at the PCO2 of 40. And here actually we have less CO2. So less CO2 will generate less bicarbonate, respiratory bicarbonate. This is why the actual in this situation less than a standard bicarbonate. Okay?
Okay.
What about the buffer base?
It's also low.
Yes, it's also low, and the base excess is negative, it's also low. So that meaning we do have a metabolic acidosis, respiratorily compensated. How do we know that this compensation is good or not?
How do we know if it's good or not? Well, it would probably worsen.
Winter's formula will tell us what should be the PCO2 value in compensation. This is the actual CO3 times 1.5, okay, plus 8, okay, that makes immediately, okay, and that should be the PCO2, the expected PCO2, okay. Oops, I have to move everything up. Oh boy. Maybe this one, okay. Nope. How can I move this crap? Yeah, I found it. See, and okay, and an additional one plus minus 2. So let's see. CO2, the bicarbonate is 8. 1.5 times 8 means 12. Plus 8 is 20. So 22 and 18 to 22, that should be the compensation. And 20, exactly the same. So it meaning that, yes, this situation, this is a respiratorily compensated situation. So the patient does not have any respiratory problem. Okay? Now, what do you think? What caused the metabolic acidosis when the patient was in shock? First of all, what kind of acidosis we had? An ion gap acidosis or non-anion gap acidosis?
None?
No.
Ion gap?
What happening when you are in shock? Bleeding, crash, circulatory shock, hypoxia, anaerobic condition, lactate will accumulate. An acid. So this is why we do have an anion gap acidosis. Okay, anion gap acidosis. Okay.
Yep.
All right. Anion gap acidosis. And I would say lactate. All right. Possible. That's a lactate. All right. Now, what will happen? What will happen later on?
So we see 1 day later that.
Yes, 1 day later. What happened 1 day later?
The pH keeps decreasing.
Okay, so the pH decreases further, all right? So now we do have an additional changes with the pH, okay? Maybe now I do have a, okay, it doesn't, no, it won't show it, okay? And
the PCO2 is increasing.
So
That's, I guess, probably due to the development of a shock lung.
So can it explain the changes of pH? Yes, because that's a respiratory alkalosis, yes? Okay, so now we do have, as you see here, the metabolic component stays the same. So if I want you to look at, for example, base excess is the same, okay, it's not changed, all right? Very similarly, we do have the decrease of the buffer base, all right? Good. And similarly, the standard bicarbonate is the same. So the metabolic portion is not changed, only the respiratory portion changed. And now we do have a mixed acid-base disorders. Now we do have a respiratory and metabolic acidosis. All right. This is due to the shock lung developed, the ARDS developed, and this is why this patient now has a combined acid-base disorder, not a simple one. That's only, this is in the same situation. There are at least two things can explain the changes of the pH. Okay. All right. Any question about this? All right. No. Looks like no question. Okay. Let's see. Bouillon.
Wow.
Oh. Okay. Now let's see.
Okay.
Now. Oops. Okay. So we do have a 35-year-old woman. Now let's see.
Okay. A 35-year-old woman reports to the emergency department with shortness of breath. She has cyanosis of the lips, hypoxia. She has had a productive cough for 2 weeks. So I guess some sputum productive, and for 2 weeks. She has respiratory problem, just for underlying reasons. Her temperature is 39 degrees, which I kind of think about infection now, inflammation.
Okay.
And then blood pressure is hypotension, is 110 and 76 millimeter mercury.
Okay, yes, but it can be normal for a girl.
Okay, and
but the heart rate is not.
Very tachycardic,
It's
108 by beats per minute. So respiration 32 per minute is very, very fast, very tachypnea, and rapid and shallow. Rapid and shallow. Breath sounds are diminished in both bases. Okay. Oh, okay. Both part of the lung with coarse bronchi in the upper lobes. So I think about the bronchitis maybe.
Well, or a little bit more, because now you do have sounds are diminished in the both bases. And if you look at, let's see later on the PO2 value, you will see immediately. Okay, let's go on.
Her acid base
parameters. Okay, let's see.
Parameters are pH 7.44. I would say it's normal.
Okay, that's in a normal range, but let's assume that you evaluate the acid-base balance. Let's assume that the normal value is 7.4. If you do have higher one, that's alkalemia. If you do have a lower one, that's acidemia. If you do have a compensation, usually the compensatory, let's see, processes will set back the pH to the upper or a lower limit. So that can be abnormal. So I would draw, let's see, an arrow up here. Okay. What about the CO2 value?
The CO2 value is lower than 40, so 28 is low.
Okay.
So that backs up our alkalosis.
Can it explain the alkalemia? Yes, because you said that's a respiratory alkalosis. Yes, so it can explain the changes of the pH. So this is a respiratory problem. Okay, what about the actual bicarbonate?
It's quite low. A
so
little bit low. Less
this
than 24, yes.
This is
It's also low.
Yes, so it's meaning metabolic what?
Acidosis.
Exactly. So this cannot explain the pH. This is why this should be a compensation. All right. And because this patient has productive coughing for 2 weeks, yes, that's a chance that the kidney will compensate because it takes about 3 to 5 days to compensate maximally. Yes. So we do have a situation when the patient had some reason why the patient had a hyperventilation, a respiratory alkalosis that shifted the pH, okay, caused respiratory alkalosis. However, the kidney started to compensate, so still kidney produced a metabolic acidosis to compensate that alkalemia. Okay, an ion gap, you have to calculate an ion gap anyway, so that's 12, that's normal. Okay. What about the PO2 value?
Very low.
Okay, meaning that this patient has hypoxia. Now, this is a hypoxemic respiratory failure, and hypoxia stimulates the breathing center as well, not only the proton production, but the hypoxia as well. Hypoxia induces hyperventilation. So possible this patient has pneumonia. And this is why everything started there. And this is how the acid-base parameters altered. How can you prove that the patient had pneumonia?
So you can do the pneumonia test. So first of all, chest X-ray.
Exactly, chest X-ray. That's okay. And after antibiotic treatment, okay, there is no COVID area when we develop these questions. All right, good, very good, very, very good. Okay, now let's see the next volunteer. Fadl, Fadl is yours.
Hello. Okay. So, a 23-year-old woman with exacerbated rheumatoid arthritis enters the ED. She has frequently vomited lately. Her medication, aspirin, 3 to 5 pills per day.
Okay. Wait. All right. Rheumatoid arthritis. Okay. Vomited lately.
Yes.
Aspirin. Okay. Now let's see.
Okay. So the pH 7.7. Partial pressure carbon dioxide.
What about 7.7 is?
High. So it's
good. We do have
alkalemia.
Good. CO2.
The CO2 is 25, so millimeters of mercury, so it's decreased.
So can you explain the changes of the pH by the CO2 value?
Yeah.
Yes, that's a respiratory alkalosis. Okay, that's fine. That's will explain it. Okay, that's fine. Good.
And then we have our bicarbonate, which is 30. This is, so it went up.
So this is a metabolic
acidosis. Oh, alkalosis, sorry.
So now we do have two parameters, both the respiratory parameter and the metabolic parameter explains the changes of pH. Again, that's a mixed acid-base disorder, yes? Okay. What about an ion gap? You have to calculate an ion gap anyway. Okay?
So
yes?
It's increased. The anion gap increased, so we have like an anion gap metabolic acidosis.
As well. Okay, now, very importantly, an ion gap is used to specify the cause of metabolic acidosis. Now, if the normal anion gap is 12, if you do have bigger than 14, you can get, okay, that's a metabolic acidosis. In that case, if we do have a acidemia due to metabolic acidosis, all right? However, independently from the pH, can be alkalemia.
Yeah.
If the ion gap is bigger than 20, we do have another hidden acid accumulation that we do have an ion gap acidosis at the same time. Okay. Now, let's see. So, if you are looking at now this one, this patient has alkalemia. That's a mixed form of alkalemia, but we do have at the same time a metabolic acidosis. good, but you don't see it on the pH.
Yeah.
Now,
so I think it refers back to the medication that
exactly. So the aspirin is acetyl salicylate. That caused the metabolic acidosis that hidden. And what caused the metabolic alkalosis?
Hyperventilation, maybe?
No. Metabolic, not respiratory. Hyperventilation can cause only respiratory changes. Metabolic, vomiting because you are losing acid. Okay, so the patient had a metabolic alkalosis due to the vomiting and has a respiratory alkalosis due to hyperventilation because aspirin stimulates the breathing center. Okay?
All right. I'm just writing that down. Yes.
Okay. Good. All right. Okay. Now, the following questions from 6, 7, and 8, you can find it in the Moodle and very precisely is given the answer. So I'm going back to, let's see, okay, pathophysiology. Go down here, okay, go down here. All right. Okay, oops. Okay, now, these kind of movies, this is going to evaluate these 6, 7, and 8 case studies. However, you do have questions. Okay, can you see the questions? Now, Hendrik, are you here?
Yeah, I'm here.
Okay, I give you the control of my mouse. All right. So, click on it and answer the question that the movie is asking. Left click. Come on. Yes. Now start the movie. Almost. Okay, I do it. Wait a minute. Don't do anything. Don't do anything. No. Now you can do it. Left click. And can you see my mouse? Okay, and move the mouse in the middle.
To understand the
Okay,
evaluation
good.
of the acid-base disorders,
Can you hear
I'm
it?
going to show you 3.
Guys, can you hear it?
Yeah, we can hear it.
Yes, yes.
Okay, listen to it, and Hendrik is going to answer the questions. Okay, good. Let's go.
Case studies that included some difficult
Come on.
mixed acid-base conditions. The case 1. We do have a 6-year-old male who presents to the ED from a nursing home. You have no history other than he has been breathing rapidly and is less responsive than usual. The important parameters you can read here, you can make a note on a paper to understand it. Serum sodium concentration is 123 millimole per liter. The chloride is 99 millimole per liter. The bicarbonate value is 5 millimole per liter, and the pH is 7.31. The PCO2 in this patient is 10 millimercury. Let's start to evaluate this patient. The first thing that we have to see the difference between the normal pH. Is there any or not?
No.
Yes, we do have a lower pH. So this meaning this patient is suffering of an acidemia. The next one, to evaluate what is the primary problem, is whether it's a metabolic or whether it's a respiratory. We have to look at the PCO2 value and the bicarbonate value. As you see here, this patient has a PCO2 of 10 millimercury, while the bicarbonate is 5 millimercury. What do you think? What could be the problem?
No. Come on, Henrik. Why? The pH was less.
Yeah, I meant to press acidosis.
And the PC, yes, the metabolic acidosis. You should go there. Okay, go there to the metabolic acidosis. Yes, and select it.
If you look at the PCO2 value, that's lower than normal. So that's a respiratory alkalosis. So the pH should be shifted toward the alkalic milieu. So this cannot be the underlying problem. Only the bicarbonate value can explain the changes. And that means we do have a metabolic acidosis. The next step, we have to calculate an ion gap. In our case, the serum sodium is 123 millimole per liter, while the chloride is 99 and the bicarbonate is 5. So the anion gap is 19 millimole per liter. What do you think?
Can you hear me?
Yes, I can hear you, but
because my internet is very unstable, so I cut out for a lot of it.
So what do you think? This is when the anion gap was. Can you remember the anion gap? What was an ion gap? It was calculated. That was higher than 14. So?
Yeah. Because 12 is the normal.
Exactly. So that means this patient has a, yes, an ion gap acidosis. Okay, good.
It is bigger than 12. Yes. So it meaning this patient has an ion gap metabolic acidosis. The next question could be, is the cause exogen or endogen? So whether the patient ingested something or not.
All right, before you answer this one, the most common cause of an ion gap acidosis, usually lactate or ketone bodies. If we do not know the cause of an ion gap acidosis, we could assume that the patient was taking something, maybe methanol, ethanol, ethylene glycol. This is a mud pies. These are most common cause of an ion gap acidosis. So to see whether the patient was taking something, what the heck happening? So if
sorry, I got a phone call.
Okay, so if the patient was drinking or eating something that could be metabolized an acidic product, that is increases the osmotic gap. So the osmotic gap is the measured osmolality minus the calculated osmolality. The measured one usually detecting by the changes of the freezing point, and the calculated one we discussed in the previous seminar, sodium twice plus urea plus glucose. And if you drink alcohol, that's an osmotically active particles. So the measured osmolality be higher one than the calculated one. So we do have an increased osmotic gap. So this is why if you want to see whether the osmotic, this is, okay, wait a minute, I close it. So is it internal or external? If it's external, the osmotic gap is increased. So the answer is here. Now you can use the mouse.
Yeah, is it the osmotic gap?
Okay, go there and click on it, and that's it. Okay, good.
I'm sorry, but I really have to take this phone. It's important.
Okay, all right. I give somebody else, okay?
Yeah, thank you.
Go and see it. Okay, Sabine, are you here?
You have to take twice the serum sodium
Hello?
concentration, and you have to subtract
I cannot hear
glucose
you.
and the urea. In our case, the urea is not given, so you
Oh,
cannot
no.
calculate osmotic
Okay.
gap.
I cannot hear you,
The
but you
next
can
one,
take the mouse,
we
okay?
have to see whether this respiratory
Try it.
compensation is adequate or not. What is the expected PCO2 based on the Winter's formula?
Yes, it's moving.
We have to take 1.5 times the actual bicarbonate plus 8 plus minus 2. So the range in our case is 13.5 to 17.5. What was the PCO2 value? 10 millimercury. So what do you think? Because 10 is less that we are having here, right here, the expected value, it's meaning.
So if the PCO2 value is less than the expected one, what else we have?
Respiratory alkaline.
Why? If it's hyperventilating, that will cause respiratory alkalosis. Not alkalemia, alkalosis. It's wrong written. Next one, above. Not that one. No. Okay. Oh, shit. This one. If the PCO2 is less than the expected one, it meaning the patient hyperventilates more than is needed. This is why we do have another underlying problem, and that's the respiratory alkalosis. Okay?
The patient is going to hyperventilate more than is needed. So the patient does have an additional problem, such as, yes, respiratory alkalosis.
Now, what can cause respiratory alkalosis? Respiratory alkalosis out of this list?
Fever.
Yes, go there, the fever, and click on it. And click select.
The next one, because we do have an
Okay,
anion gap.
before we continue, I will explain you what the corrected bicarbonate is. Because, let's see. Okay, I try to find, I think this is, okay. Now, if somebody has an ion gap metabolic acidosis, what will happen? It's meaning that the changes of bicarbonate, so the decrease of the bicarbonate is equal with the increase of an ion gap, because as much acid produced, the bicarbonate decreased and an ion gap increased. So if you do have the same changes of the anion gap as a bicarbonate, you know that there is no other underlying metabolic processes. Okay, it's clear?
Yes.
Okay. However, if, for example, you have a bigger change of the anion gap than a bicarbonate, what does it mean? You do have much more acid accumulation than the decrease of bicarbonate. So it's meaning that we do have a more bicarbonate that we should be. That patient has a metabolic alkalosis. However, if the anion gap doesn't increase as much as the bicarbonate decreased, meaning that in addition to the acid production, we do have an additional bicarbonate loss. So we do have a non-anion gap acidosis. You can use this delta-delta comparison, but usually what they do, they correcting the actual bicarbonate with the changes of bicarbonate, changes of an ion gap. So we do have the measured bicarbonate and we add how much was the changes of an ion gap. Now, if you do have less bicarbonate, exactly the same as an increase of an ion gap, exactly you will get back the normal bicarbonate value. So the bicarbonate value be between 20 and 26. So there is no other metabolic component. However, if the measured bicarbonate relatively decreased more than the anion gap increase, we do have a non-anion gap acidosis. And if we do have relatively more, the sum of the measured and the delta anion gap is more than 26, we do have a metabolic alkalosis at the same time. Okay. Now, if we go back to these movies.
Can I ask a question?
Yes.
When we say that the change of Y, the change of anion gap, when it's higher than the change of the bicarbonate,
yes,
why don't we consider it a metabolic acidosis? We have more.
Okay, let's see. Because the acid buffered by bicarbonate. All right.
Okay.
So it's meaning that the proton is neutralized by bicarbonate. And if you do have an equimolar, let's see, ratio between the loss of bicarbonate and accumulation of the proton, that meaning that, okay, this is no additional problem. But if you do have a ton of, let's see, proton, but you still have a lot of more bicarbonate, it's meaning that you do have an excess of the bicarbonate. So it's meaning that you do have a alkalosis, a metabolic alkalosis. Another process, for example, vomiting causes a metabolic alkalosis, but you do have an acidosis due to the keto acids. So these two situations side by side working. Okay.
And for non-AG acidosis, we can mention maybe diarrhea and renal tubular.
Yes, exactly. Yes. So, for example, in this situation, what we have, that the metabolic disturbance, we have, as you see here, 12. So it was the bicarbonate is 5, plus the changes was, in this situation, was 7. So this together is 12. So this patient does have a additional non-anion gap acidosis, yes?
Acidosis. We do want to see whether we do have other underlying metabolic disturbance. For this, we have to calculate the corrected bicarbonate. The corrected bicarbonate is the anion gap changes is correcting the actual bicarbonate. In our case, 5 plus 19 minus 17, that makes 7, and that means 12 millimole per liter. So the corrected bicarbonate is less than 22. So this patient has a...
No, what the patient has? The patient has?
Acidosis.
Yes, exactly.
Additional non-ion gap acidosis.
Now, what could be the cause of a non-anion gap acidosis? We discussed this one.
Bicarbonate loss?
Yes. The vomiting is the alkalosis because you're losing acid.
What is the next? How can we figure out what the cause is of the non-anion gap acidosis? Yeah, you have to calculate the urine anion gap if you had the urine values.
And if you want to figure out the cause, whether this is a GI tract or this is a kidney, now you can measure the urinary anion gap. You can measure the sodium potassium concentration in the urine minus the chloride concentration. And if it's very negative, especially when we do have an acidemia, that meaning it's okay, the tubulus is working and excreting the proton. However, if it's very positive, that meaning cannot excrete, so you do have a kidney disorders. Okay.
Sodium, potassium minus the chloride. If it's very negative, less than minus 10, there is no problem with the kidney, so that has to be some GI problem. However, if it's bigger than plus 10, you have to think about a kidney problem, renal tubular acidosis, especially the distal type. The next case we do have
Ali Reza is yours.
female who has type 1
So
diabetes.
the mouse is yours.
And now she has a flu for 4 days and together with the incessant vomiting. So she cannot stop vomiting, very frequently vomits. She presents to the ED 2 days after stopping insulin due to no food intake. Now that's a bad, because this is the first that they are learning that we have to have an insulin without any food intake, because the basal insulin is needed. We do have sugar in our blood, so this sugar needs some insulin to be uptaken. Now let's see the parameters. Serum sodium is 130 millimole per liter. Chloride is 80 millimole per liter. Bicarbonate is 10 millimole per liter. The pH is 7.21 and the PCO2 is 25 millimercury. So let's start the evaluation. The first thing to again, look at the pH. Is it less than 7.4? Yes.
So
acidemia.
Okay. Come on.
Mouse. It's on my iPad.
Oh, well, okay. So say it and I will do it, okay?
So it meaning this patient also has acidemia. The next one is whether this process or this abnormal acid-base balance is due to metabolic or respiratory problem. We have to look at PCO2 and bicarbonate. Is the PCO2 is less than a normal, the 40.
So here the arrow pointing up is not good, because
so
if you do have less PCO2, that's it causing an increase of the pH.
So this patient does have a metabolic acidosis. Go on, next one. Calculate an ion gap. In our case, sodium is 130, chloride is 80, bicarbonate is 10, so that means 40 millimole per liter.
It's very, very high. It's an ion gap.
Very good.
Acidosis. Let's look at the respiration. But before we go to the respiration, what could be the cause?
It could be lactate acidosis.
If you do remember, what was the problem with this patient? Okay, so
ketone bodies, yes, ketoacidosis.
Okay, so present accumulation of ketone bodies. All right. Okay.
Now, in our case, because this patient has type 1 diabetic mellitus, and especially he stopped the insulin administration, she has a very high chance to develop diabetic ketoacidosis. So if you measure the ketone bodies, possible it's very high. Next one, the respiratory compensation is adequate or not. The expected one ranging between 21 and 25 millimercury, and she has 25, so she does not have any other respiratory disturbance, so she has a normal compensation. Because we had an ion gap metabolic acidosis, we can evaluate whether we do have an additional metabolic disturbance or not. Let's calculate the corrected bicarbonate. 10 is the bicarbonate value, 40 is the anion gap minus the normal anion gap, that means 38. 38 is bigger than 25, so it meaning this patient has, yes, an additional metabolic alkalosis. Now, what could be the cause of this metabolic alkalosis?
No.
Vomiting?
No, exactly, vomiting. Yes, that's it. Vomiting.
Possible, the vomiting. Hopefully, now you can see how you are going to evaluate an acid-base balance. See the last case.
Okay, now
She's a
Buyong, it's yours, okay? I'm controlling the mouse and you is going to answer it, okay?
With neutropenic fever, has been receiving multiple antibiotics, including amphotericine B. You are called to the bedside for her fevers, rigors, and dyspnea. Serum sodium is 125, chloride is 100 millimole per liter, bicarbonate is 8 millimole per liter, pH is 7.07, PCO2 is 28, and the potassium is 2.5. Let's start the evaluation. Look at the pH. Wow, it's very acidic one. So this patient again has acidemia. Now what caused this acidemia? Let's look at PCO2 and bicarbonate. PCO2 is 28 millimercury. Again, this is
so again
less
that is
than
increases the
40,
pH,
so
not
that's an
decreases the pH. So that's again
respiratory
is a
alkalotic
bad one.
processes. However, the bicarbonate is decreased, so that's a metabolic acidosis. Let's calculate an ion gap. Serum sodium is 125. Chloride 100 plus 8 means 17. So that's bigger than 12. So we do have an ion gap metabolic acidosis. What could be the cause?
No, what could be the cause in this situation?
I saw amphotericine B in the sorry. AG metabolic. Okay, so AG metabolic is vomiting.
What? We do have this patient has an ion gap acidosis. Read the okay, and this patient has fever and the patient has inflammation. So
lactate accumulation.
yes, that could be the lactate accumulation.
I think I just went to diagnosis.
She had neutropenic fever, infection, so an inflammation that caused lactate acidosis. You should measure the lactate, and if the lactate compensates an ion gap back to normal, you do have the direct answer that yes, it's correctly due to lactate acidosis. Next one, the respiration is adequate or not. Expected PCO2 is equal with 1.5 times 8 plus 8. That means between 18 and 22. And she has 28. So what does it mean? She could not hyperventilate as much as needed for the normal compensation.
So if your patient cannot hyperventilate as much as needed, what additional problem she has?
So if you don't ventilate enough, the CO2 is still remaining in the lungs, so they can cause acidosis.
Respiratory acidosis.
Yes, respiratory acidosis.
As you see here, we could have respiratory acidosis having less than 40 millimercury of PCO2. So not only bigger than 55 can cause respiratory acidosis, but when you cannot, let's see, compensate, again you can have respiratory acidosis.
Having less than 45 millimercury of carbon dioxide is depending on the compensation or compensatory situation. Next one, because we still had an ion gap acidosis, let's see is there any other metabolic disturbance. Let's calculate corrected bicarbonate. Actual one is 8, and an ion gap change is 17 to 12 is 5, so this 13 millimole per liter. So she has an additional non-anion gap metabolic acidosis. What could be the cause?
No, that's your good question. What could be the cause of a non-anion gap acidosis?
So this one is due to the amphotericin.
Exactly, because amphotericin B,
yes.
what will do?
It will have nephrotoxicity and work on the channels and the tubules of the kidney.
Making pores and causes a hydrogen ion redistribution, diffusion back, okay?
Yes.
Good. So I'm going to amphotericin B and select it.
How amphotericine works. That's an antifungal agent that makes pores on the cell membrane, and this can cause a diffusion of the hydrogen in the distal tubular system. So possible the causes of the amphotericin B treatment, and that causes renal tubular acidosis.
Okay.